Good afternoon, everyone, and welcome to today's Fireside Chat. I'm Amna Hussein, the Community Outreach and Engagement Manager at the Masonic Cancer Center at the University of Minnesota, your host and moderator for our monthly Fireside Chats. The Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. Our office serves as a vital bridge between the Cancer Center and communities across the state of Minnesota and beyond. Our small but mighty team is committed to reducing the burden of cancer by actively engaging communities and providing access to relevant knowledge on the latest in cancer research, prevention strategies, the importance of screening and early detection, treatment options, survivorship, and opportunities for clinical research. Each month, we host these fireside chats to share knowledge, raise awareness, and highlight the people and research driving change across the cancer continuum. Today's conversation focuses on the science of health behavior change. In many ways, this is something we all encounter, whether in our work or our own daily lives. We often know what we should do to improve our health, but actually making and sustaining those changes can be much harder. And that is why today's conversation is so important. And so this session will explore the science behind how people initiate and sustain health behavior change and what it means for how we design programs, engage communities, and support individuals in improving their health outcomes. So to guide us through today's conversation, we are honored to be joined by Dr. Alex Rothman. Dr. Rothman is a professor in the Department of Psychology at the University of Minnesota and is a leading expert in the field of health behavior change. His research examines how people process and respond to health information and how those insights can be applied to develop effective, theory-driven interventions that support healthier behaviors. Working across a broad range of health areas, including smoking, diet, physical activity, and cancer screening, his work has helped us better understand when health communication strategies are most effective, what drives people to initiate and maintain behavior change, and how to better connect theory, practice, and policy in ways that improve health outcomes. His work has also informed the design, implementation, and evaluation of interventions across these behavioral domains. Dr. Rothman has also served as president of the Society for Health Psychology and was the founding president of the Social Personality and Health Network. He has contributed to a number of National Institutes of Health and National Cancer Institute initiatives, further reflecting his leadership and expertise in this field. We're truly fortunate to have him guiding today's conversation. And before I pass things over to him, I would like to cover just a few quick housekeeping items. So today's fireside chat will be recorded and posted to the Masonic Cancer Center's YouTube page by next week. We also have closed captioning available for this session, and you can turn that on by clicking the CC button located on the bottom of your Zoom screen. For University of Minnesota employees and spouses participating in the university's employee well-being program, you can claim your 200 well-being points for attending today's fireside chat by completing the form that I will be dropping in the chat shortly. We also invite you to engage with us throughout the session, so utilize the Q&A feature located on the bottom of your Zoom screen to submit any questions you have, and we will have time carved out at the end to take some questions with Dr. Rothman. All right, without any further ado, I'm going to hand things over to Dr. Rothman. The virtual floor is all yours.
Thank you, Amna. Here, let's now do the virtual handoff. Okay. Share that and that. Okay. Amna, we're good on your end, and I guess everybody's end?
Yes, it looks great.
Okay, great. Well, good afternoon, everybody, and thanks. Well, maybe first, thanks to Amna and her colleagues for inviting me to join you all today, and thanks all of you for taking the time this afternoon, particularly on a particularly beautiful day, to spend a little time talking about the science of health behavior change. Just quickly, I don't have any disclosures or conflicts of interest to note. So let's get right into this. So Um, this is a time of what I sort of think of as like tremendous opportunity. And what I mean by that is that those of us who are interested in strategies that can help people make and sustain changes in their behavior, the evidence is pretty clear that behavioral practice have an important implications for health. This is something my guess is I hope all of you sort of have an intuition about. Here are a couple of slides on the right illustrates the contribution of behavioral patterns to premature death. The sort of the bar graph on the left. Sorry, now I need to make sure that okay, there we go. Provides us a slightly different look at this. And with this, I'll just describe this very briefly. This is a graph from a paper from a while ago in Circulation about estimated life expectancy. And really what I want you to sort of get a sense is as the bars go from left to right, it sort of talks about the life expectancy after 50 that you expect for engaging in 1 to 5 low risk behaviors. And so these are things like never smoking, having a BMI between 18.5 and 24.9, et cetera. And it sort of illustrates both for women on the left and men on the right that there's a sort of very systematic benefit to engaging in these sort of healthier patterns of behavior, affording almost maybe a 12 to 15 year gain. And we see behaviors elsewhere. So this is the cancer control continuum, sort of put out by the National Cancer Institute. And throughout the different parts of the cancer control continuum, you also see behavior playing a role. You can see it in each phase. It sort of drives the etiology of cancer. It's involved in prevention, detection, diagnosis, treatment, and survivorship. And so, in a sense, the challenge of helping people as they manage their behavior, to maybe initiate changes and to sustain changes in behavior is something that is of relevance almost throughout the landscape, the health landscape. And really the question that people like myself often grapple with is so how do we help people initiate and maintain changes in their behavior? And this is the topic that I'm going to talk to you about today. And so let me take a moment, though, to give you sort of a brief overview. I was talking with Amna before we got started. There is, in a sense, so much to talk about that I'm really just going to give you sort of some snapshots about a couple of different things. And then, we'll make sure to have some time at the end for questions so that we can talk about what I've talked about or other things you would like to put on the table. So what I'm going to do today is I'm going to talk first a little bit about just how we approach advancing the science of behavior change. And this is sort of like, how do people like myself and others sort of think about the science of behavior change? And I will take within that an opportunity to talk a little bit about some of the things we have thoughts about in terms of the mechanisms or the factors that drive initiation and potentially maintenance of behavior change. Second, I hope to have time to sort of give you 2 brief snapshots of some work that my colleagues and I have done to better understand health behavior change, one in the domain of smoking cessation and the other in the domain of physical activity. And then I'm going to wrap up by just showing you sort of where I think we are headed and highlight what I think are some sort of 3 key questions. These aren't the only questions, that need to be prioritized, but 3 to consider. So let's talk about now the first sort of phase. So, as is often the case with opportunities, they often come with challenges. And so the benefits of behavior change are clear, but how do we capitalize on those benefits? And the reality is there's really no shortage of strategies or what I might term tools in our behavior change toolbox, right? So there are numerous things. In almost a sense, one of the challenges really is there are so many different things we could do that the challenge really is thinking about how does one decide which strategy or set of strategies one might use to help people make changes in their behavior. Now, one of the things we also need to think about as we start to think about these strategies is what actually are the tools in the toolbox, right? So, in our normal toolbox, we have a pretty good sense. There's a hammer, there's a saw, there might be a ruler, a balance. But so the question is sort of what is actually in this behavior change toolbox? And someone who I've collaborated with a bit, but not necessarily on this particular work, Susan Mickey, and her colleagues have offered us a taxonomy, what she calls the behavior change technique taxonomy. And what Susan and her colleagues did is they work to organize sort of all the different techniques that are available into sort of a hierarchical taxonomy. She identifies 93 different techniques. This is much more than I can sort of go over with you today, but I just wanted to sort of help you appreciate. So there's sort of a typology available that says, hey, here are 93 different things we have, sort of sense 93 different tools in our toolbox. I've sort of in the bubble here just pulled out what some of those might be. These are sort of the overarching categories. So there are things we might do around goals and planning. For example, we might sort of try to help people develop action plans to guide their work. There's strategies that focus on feedback and monitoring, so systems that allow people to self-monitor their behavior. There might be classes of strategies that help people compare what they're doing to what either to objective standards, what other people are doing, engaging in social comparison. We might provide people with prompts or cues or reminders. We might do things involving restructuring the social environment, restructuring the physical environment, and so on. This is just a touch. So there are innumerable things in this sort of in the toolbox. But the tricky thing is it's one thing to sort of maybe have a good organizing list of what's in the toolbox, but we really need more than a list, right? To really move forward, we really need to help people make decisions about, well, what should I reach for, right? So again, to stay with my toolbox metaphor, most of us know that if we have a screw, we might want to reach for a screwdriver, right? And if we have a nail, we'd want to reach for the hammer. So the same sort of thinking is here is what's the guidance? Like when you reach into that behavior change toolbox, what should I take, right? What should I pull out? Should I think about using reminders? Should I think about providing people with systems that allow them to monitor their behavior? Should I provide people with incentives? And this is really key. And one of the things I find in my work is that when I'm in conversation with interventionists and policymakers, they really want to know answers to that question. They want to know, what should I choose? And it makes sense. Interventions and policymakers, they need guidance regarding which strategy or sets of strategies should be used and when should they be used, sort of for which behavior, right? So what strategy should I use if I'm trying to help people quit smoking versus I'm trying to help people be more physically active versus I'm trying to get people to participate in a screening regimen or to take their medication, right? And so the question is to what extent, do the strategies that I select, are they similar? Are they different across those behavior domains? And to what extent might it depend on the context in which people are living or the background or resources that somebody has? And these seem like excellent questions. And so the real challenge is this to answer is sort of the question of, well, what tool should I use? Is that we need to develop, and I think sort of investigators like myself and who are working in this area, we need to sort of develop an evidence base that can provide this kind of guidance, right? So we want to develop an evidence base that we can sort of use, that you can turn to and sort of say, hey, now I know from this evidence base, what tool should I use? And so what I want to sort of now just talk a little bit about is sort of how are we approaching developing that evidence base? And what I want to emphasize is that the approach that really has emerged over the past, I would say 15 years, has been a set of frameworks that are designed to support our understanding of health behavior change. And one thing that links all of them is they're all grounded in what I describe as what I'll call a mechanistic approach to behavior change. And I'll unpack that in a moment. They all sort of end, so I've put sort of 3 of these sort of different kinds of approaches in the screen, and I'll return to the bottom 2 briefly at the very end of my talk, just as an indication of resources. So there's some other places you can look for information. But today, I'm really, sorry about that. Today, I'm going to sort of really focus on what is sort of the approach characterized by the science of behavior change. And so let's talk a little bit more about what that approach looks like. So in this case, I'm going to sort of talk about sort of what does it mean to take this mechanistic approach to behavior change. So what does it mean? And so what it sort of takes as a perspective is the idea that intervention effects, and we'll look at sort of what I'll call the sort of the illustrative cartoon that's on the slide. Intervention effects can be thought of as a function of sort of 2 change processes. 2 kinds of things have to happen. There is what is on the right side of this screen is sort of the path that leads what targets, or sometimes I will call them mechanisms or mechanisms of action. These the idea is there are some sets of phenomenon that if we could that are able to elicit change in that outcome of interest. Okay, and so the idea here is there are constructs that if we changed people's levels of them, how people thought, how they felt, that those changes would elicit a change in the outcome of interest, a behavior, maybe exercise or smoking or following a treatment recommendation. And then the other path is on the other side, and this sometimes we call the engagement path. And the premise here is that there's an intervention strategy or set of strategies that are able to elicit a change in that targeted mechanism. And so what you can sort of think about these sort of simplified cartoons, and I'll show you some more examples in a moment, but this is just this sort of one form, is the idea is that the journey, the way the intervention produces a change in behavior is through this journey, through the target, through this mechanism of action, right? So I sometimes, when I talk with my colleagues or talk with my graduate students, I often think of these as roadmaps, right? How am I getting from Minneapolis to Kansas City, for example? How do I get there? What do I have to travel through? It's the same idea. How does the intervention get behavior change to happen? And the argument is it's through its ability to change these mechanisms that in turn lead to changes in behavior. And as I said, these can come in a variety of different forms. Oh, sorry, I forgot my little heart here. So really at the heart of this mechanistic approach is trying to understand these targets, right? This is sort of the heart of the problem. So as I said, there are a number of different ways in which these things, and this is again just a sort of again another sort of snapshot of different forms these can take. And so these are sort of, you could think of these as sort of different roadmaps. And so, for example, on the left side of your screen, you could think about an intervention could be designed because you wanted to engage two distinct mechanisms, right? So it could be that the intervention is designed to both motivate people to be interested in the change in behavior and also increase their sense of ability or capability in enacting that behavior. On the right side of the screen, it could be that what the intervention does is it operates through a sequence of mechanisms. Okay. In this case, it might be that you have to first engage people, get them to feel a sense of personal relevance, that this issue is something that is pertinent to them or their loved ones, as it might be, and that sense of relevance then motivates an intention to act. And so there's a sequence of mechanisms that have to occur. That they go in that, and it's then that intention that drives behavior. Or if you look at the bottom, in the bottom sort of center, it could be that we're going to need two distinct intervention strategies to engage, and one each to engage these different targets. Sometimes I like to think of these as sort of levers, right? So that we have to pull lever A to engage a particular mechanism, and we pull lever B. And so we might need to provide people information about the consequences of engaging in a behavior or not engaging in a behavior in order to increase their motivation. And then separately, we'd have to give them, let's say, skills training to increase their sense of capability. And so it's a separate intervention strategy to use, each to engage with a distinct target. Now, when I talk about these things, one of the things I like to just remind people or just to sort of have them keep in mind is that targets can take sort of a number of forms, but in particular, they can take two key forms, which is there are targets or mechanisms that are constructs that facilitate a behavior. These are things we want to increase in people. We want them to be present. We want to increase their presence. We might want to improve people's attitudes towards a behavior. And the idea is that by increasing that construct, it will facilitate behavior. But mechanisms also can take a different form. They can also be constructs that inhibit a behavior, right? So these are things that we would want to reduce or lower, right? These are things that are sort of standing in the way of people acting. And I note this only because often when we talk about interventions, we tend just to sort of almost our mental habits are to think about things that would facilitate, that would help people take action, when often sometimes the real challenge is lowering barriers, removing things that are impeding their action. So, okay. So at the heart, again, of this sort of mechanistic approach is it's all predicated on the idea that there are constructs that we can identify that can be manipulated. These are things about people or the context of the situation that we can change, and that changing them leads to a meaningful impact on behavior. Now, how we go about this is sort of the nuts and bolts of doing this is really beyond time I have today. But I'll just sort of note that if you're interested in this, there's a more sort of hands-on detailed overview of how to sort of use this approach in in a volume called the Handbook of Behavior Change. So we have a chat. My colleagues and I have a chapter, and if that's it's available. Maybe everybody doesn't have access to the university library, but for those of you who do, I know it's electronically available there and hopefully in other libraries. What I'd like to sort of transition to, though, is that when we think about targets, the challenges gets even more interesting when we try to think about constructs that we might need to engage in order to increase both the initiation and the maintenance of behavior change, right? So this is like, so what happens when we take this mechanistic approach and try to map out strategies that will allow us to promote sustained behavior change? And in doing this, one of the things that my colleagues and I have suggested is that as we think about, well, what is it that would help, what is it that helps people maintain behavior, we've suggested that we might want to think about sort of three classes of targets or mechanisms, sort of three things. And so, and the first class is what we call what we've sort of called initiation targets. These are constructs that, when engaged, elicit initial changes in behavior. And we recognize that, the specific things that people might be interested in may vary across behavioral domains. We might want to do slightly different things if we want to change people's eating behaviors, their activity, their sleep, their smoking, to name but a few. But reviews of the literature have identified a number of potential candidates, and I've identified a few here. These are things that we tend to know that if we can engage with these constructs, it helps people get going. It helps them initiate changes in their behavior. These are things like outcome expectations, people's intentions, their self-efficacy for the task, their ability to identify and engage with and modify barriers, ability to set goals. And the thesis here, though, is that what these things do, if we can change these targets, it helps people start changes in their behavior. And it's those changes in behavior that then translate on their own into maintained changes. And that's why we call these initiation targets. Now, to complement those, there's a second set of targets, which we call initiation and maintenance targets. And what the idea here is that these are constructs that, when engaged, they're hypothesized to both help people make initial changes in their behavior, but also to continue to support them as they work to maintain those changes, right? So it helps you get going, it helps you get to start maybe a new activity regimen or start a new pattern of sleeping habits, but this also then helps you sustain or maintain that change in behavior over time. And here again, the literature has identified a number of potential candidates, things that could be sort of particularly focus of interventions. And there are things like self-monitoring and the feedback that associated with self-monitoring, the experience of enjoyment, ability to self-efficacy for coping with challenges that maybe are associated with engaging in those behaviors, the availability of material resources. And again, the thesis here is that engaging these targets support people both to initiate those changes in their behavior and their ability as they work to strive those changes. Although it may be in some cases that their contributions might vary. And so they contribute to both, but they might be a little more important for one or the other. The third set of targets I want to just sort of raise or put on your mind is then what we call, and you probably anticipate this, sort of maintenance targets. And here, these are constructs that are hypothesized that when we engage with them, they underlie and support maintaining changes in behavior. The argument here actually is that these constructs are, these may be attributes, thoughts, feelings, skills that might emerge from an intervention or might emerge from engaging in the behavior. And the argument here is that these are basically uniquely applicable to the tasks associated with maintenance, right? So here are things that we might want people to experience or do or feel, and that their benefit really accrues as they're trying and working to maintain changes in their behavior. And the potential targets that have been identified here are things like autonomous motivation. This is sort of, you maybe think of this like sort of intrinsic motivation, sort of that not externally motivated concerns, but internally motivated concerns that drive your behavior, the development of routines and habits, the experience of satisfaction with the outcomes, that sort of you have a sense of satisfaction with what has come from engaging in this pattern of behavior, and the formation of a sense of identity. And again, some of these variables may be more or less pertinent to different behavioral domains, but the broad idea here, key thesis here, is that engaging in these targets serves to support people as they strive to maintain changes in their behavior. Now, these are three different classes of targets, and we might want to think about sort of, so having a list of targets is really helpful, but it only gets us so far, right? So these are all promising targets for intervention, but to be able actually to leverage them, we need more than just a list of targets, right? Um, so in a sense, having a list of potential targets to engage with is, as maybe one could say, is sort of necessary but not sufficient. We also need to identify then event intervention techniques that effectively and hopefully efficiently can engage with these targets, right? So if we want to promote certain, constructs or experiences, can we do things that would actually facilitate that? And, as I said earlier, at present, our behavior change sort of technique toolbox is full, right? There are a lot of things in it. But one of the things is that we've observed, perhaps not surprisingly, is that the majority of these techniques tend to be focused on targets that we think are primarily involved with engaging initiation targets, right? And so in some sense, if we look, in some sense, when we look in our toolbox, we primarily find that there are intervention techniques that are probably designed to go after these initiation targets. And perhaps maybe that makes sense, which is sort of you got to get people started before you can actually work on helping them maintain. So one way I sort of like to illustrate this is some data that emerged from a project that I did with some colleagues, where we looked at actually physical behavioral trials to promote physical activity, the adoption and the maintenance of physical activity in sample. These were all trials done with actually with cancer survivors. And one of the things that we were interested in looking at in this case, and what I want to focus just briefly on in here, is we wanted to just see, well, what kind of intervention techniques are they actually using in these interventions? And so one of the things we were sort of interested in is if we go looking in these interventions, and so we went through them all and we coded out the intervention techniques that the trials used. And what we were interested in seeing is, how many times are these interventions using techniques for initiation? How many times are they using techniques that we think might be involved in engaging with targets that both support initiation and maintenance? And how many times are they using techniques that involve engaging with what we was calling maintenance targets? And what we found and what we can see is that a couple of things. First of all, we were able to there are many, many more. We're looking, as you can see, the top set on the screen on your left are the longer set. At the top are all techniques for initiation, and you can always see there are many more. There are 22 of those. The middle set of bars there were 11 of those techniques for initiation and maintenance, and then at the bottom only 8 techniques for maintenance. The sort of evidence, and what's consistent with what I had said earlier, is what we find is that by and large, trials on average tended to use 6 of these. They might have used different trials use a different mix, but on average they tended to be comprised with 6 different techniques that really focus on initiation targets. On average, they might have utilized 2 techniques that engage with initiation and maintenance targets, and then really the take-home message from us is they hardly ever, and that's 0.15, they hardly ever use techniques that are involved with maintenance targets. And we can sort of look at this in a slightly different way. So that was the sort of mean number of techniques that are used. This would just be on average what percent of trials used initiation techniques, and sort of the average level of use was about 21%. And you can see that drops for the maintenance things down obviously to a very small number, 1%. And the sort of takeaway I sort of want you to leave with at this moment in time is that we're sort of in a challenging space in here, which is that we have some ideas about possible mechanisms, possible constructs we could engage to help support sustained behavior change. But we actually need not just ideas about mechanisms, we also need techniques. We need to identify and develop techniques that can be used to engage those targets, and we have to use them in our trials. And in a sense, you can't test the impact of these targets if we don't use intervention techniques to go after them. So, okay. So I'm going to sort of put a pin on that, and I'd like to sort of take the sort of next sort of chunk of my time to really now talk with you about, as I said, two snapshots, just sort of two things that two lines of work that we've done here at the University of Minnesota with some of my colleagues in different departments that sort of help, that sort of different, that give you just two different ways we've been thinking about and approaching the study of health behavior change. One sort of focused on smoking cessation, that's going to be ultimately sort of about mechanisms, and one about physical activity that really is more about intervention techniques. So let me turn to those. I apologize. I'm going to have to sort of, these are going to be sort of brief snapshots. In each case, I've sort of pointed to the intervention article, the article associated with it, and I'd happy to answer more questions in the Q&A or if need be after. But here, so the first one, as I said, was in smoking cessation, and maybe many of you know that most smoking cessation programs tend to have this sort of standard structure. They tend to be 8-week programs, right? And so you enroll and you participate, and it's sort of at the end of 8 weeks, it's over. My colleagues asked the question, well, what would happen if we actually treated people for longer? What if, what happens if we treated smoking as more a chronic condition and sort of approached sort of using a more longitudinal care for smoking cessation? Now, in this case, you could sort of say, well, why the care could just go on and on and on, it doesn't have an end. In this case, in the context of an NIH-funded trial, it did have to have an end. So what we tested was the idea of, well, what would happen if we actually we allowed care to unfold for a whole year? So we offered people a year of treatment. So what does that mean? What does that look like? We recruited smokers who were interested in quitting. They all were enrolled in a standard treatment program comprised of sort of phone counseling to support people and free nicotine replacement therapy. And everybody ran for the sort of run in 4-week period, right? So everybody got the same exact treatment for 4 weeks. But then at 4 weeks, people were randomized to one of two conditions. Either in the usual sort of discrete care condition, they got 4 more weeks of treatment, and they sort of got the program as it normally is run. The other half, though, were randomized to what we call longitudinal care. And so they actually the treatment was available for a full calendar year. We followed people over time, including then ultimately 6 months after the end of that year of treatment. The question was is sort of what would happen? Like, what would happen if we give people this longitudinal care condition? And so what did we find? If you look on the left side first, and sort of you'll see two different outcomes, but they both show the same sort of effect, which is that over time, the people who were given the longitudinal care treatment were more likely to successfully quit smoking. Maybe we'll focus the top graph on the left sort of is looking at an outcome that is a prolonged abstinence of 6 months, measured at least 6 months, measured at 18-month outcome. And so what you can sort of see is that people who got longitudinal care had a higher rate of successful long-term cessation. The table on the right of your screen sort of we're looking statistically. We're trying to say, well, what predicts being having success? And what we find, I want to highlight sort of two things. Getting assigned, as I just sort of noted, getting assigned to the longitudinal care arm was important, but also was having success right away, right? So be smoke-free at day 21, sort of 3 weeks into the trial, was also a strong predictor of long-term success. And this was interesting to us because it helped us think, it informed sort of some of our thinking about, well, why might longitudinal care be helpful? And our thinking is that longitudinal care is going to be helpful, particularly for people who are struggling to quit, right? So the idea would be, if you're sort of taking 2 steps forward, 1 step backward, or 1 step backward before you take 2 steps forward, right? If you're struggling to quit, having somebody available for an extended period of time would really be quite helpful. And for people who were able to sort of quit early on and just stick to it, they probably don't necessarily benefit or need longitudinal care. And so we had this hypothesis is that longitudinal care would be especially beneficial for smokers who struggle to quit. And it would do that because it might do a couple of things for them. It might make them feel a greater sense of self-efficacy, that they in fact can do this, perhaps even despite the fact that they're struggling. It might help them maintain their sort of eagerness or motivation to readiness to quit. And it might help them feel a better sense of satisfaction with their efforts, right? And this is particularly in the face of in the context in which they're struggling. At that time, my graduate student at the time, Rachel Burns, she's now professor at the University of Ottawa, sort of led this part of the project and was looking at this and was sort of interested in this idea that did longitudinal care help people become smoke-free because it helped increase or supported their sense of self-efficacy, their satisfaction, and their readiness. And was that particularly true for people who were smoking along the way, who were smoking at 3 months or smoking at 21 days? And so the idea would be it's the people who are struggling, who are benefiting from our treatment, our longitudinal care program, and so let me just sort of show you some data. In fact, that's what we found. It's sort of the graph on the left sort of shows you this, which is this is percent quit at 12 months. We sort of do these in sort of a series of time intervals. This is just one example. As you can see, it's people who are smoking at 3 months into the program. They benefit from longitudinal care. The people who were not smoking at 3 months, there's a small advantage, but there's really no significant difference. There doesn't, if you're doing well, being assigned to longitudinal care really wasn't that very helpful. And in fact, we found that benefit, the people who benefit from longitudinal care and are smoking, it's because it helped them feel a sense of satisfaction, a sense of readiness to quit, and a sense of cessation, and a stronger sense of cessation. So it actually provided us with some answers about why that longitudinal care works, right? We have an idea for whom it works, and we have an idea for why it works. If people are interested, we actually have done follow-up work in this area. This is the paper reporting that we've sort of focused on sort of trying to figure out what's the optimal content and timing of the delivery of longitudinal treatment, right? So, and again, like several things I've noted, I'd be happy to talk about that at the end. But I want to have time to just show you one other window into some of the work that my colleagues have done. This is now work in a very different domain. And in a sense, because I'm very much interested in sort of these sort of the sort of understanding the theory and the mechanistic processes, I'm somebody who actually works across a wide range of domains with different collaborators. This is a different set of collaborators, some in nursing and kinesiology, where we were interested in trying to figure out how do we get older adults to engage in more physical activity and sustain that level of physical activity. And as some of you may know, or whatever, we have a pretty good idea, and there actually are good sort of strength and balance and exercise programs that older adults can engage in that are beneficial. And it's been a challenge to just sort of get people to sort of adopt them, particularly people who are inactive. And so what we were looking at, and this is what you can sort of see on the screen, is that we had a program that is effective. It's an Otago program, modified for small groups, which is how we're going to deliver it. And the question that we were grappling with is, well, what should we complement that physical activity program? What kind of behavior change strategies might be most effective? And we sort of examined the relative contribution of sort of two broad classes of behavior change strategies, what I'm going to call interpersonal strategies and intrapersonal strategies. And I'll describe those for you in just a moment. And so the idea is that everybody in this trial, everybody is going to get the same fitness program. And then some people are going to get that fitness program along with some of these intrapersonal strategies. Some of them are going to get it with intrapersonal strategies. Some of them are going to get it with both, and some are going to get it with none, which would allow us to sort of look at the relative contribution. Like, do certain strategies, are they more beneficial, more effective in helping people engage with these motivate people to sort of engage with the physical activity programs they're being offered? These are individuals who are 70 years or over. There's a point to the report of the study. So, how did this work? They did this in small groups of participants. They met once a week for 8 weeks. There's something magical about 8 sometimes, I guess we think about. The sessions were about 90 minutes. And as I was saying, the sort of one group just really got the physical activity training and some general information about aging and health. And then another group got either intrapersonal behavior change strategies, interpersonal behavior change strategies, or both sets of strategies. And so those are the 4 groups. And this is a description of what that might have been. So you can think of intrapersonal behavior change strategies are sort of personal-based monitoring and assessment kind of things, right? So you're self-assessing your progress, you're figuring out, you're going through daily routines, you're monitoring your behavior, you're keeping records, you're sort of developing personal goals, right? It's very intrapersonal, intrapsychic. Interpersonal behavior change strategies, on the other hand, have a very different flavor, and they by and large involve mostly just doing some of the engaging with some of the same issues, but through peer discussion, right? So in the conditions where you got the exercise and the interpersonal behavior change strategies, it was much more likely to be the sessions involved sort of peer discussions about social support, about how do you solve for problems, how are you doing, what's your experience, right? It's really much more of an interpersonal exchange, and so we were interested in whether one or both of these strategies do that. Maybe they both contribute, or does one contribute more than the other? So what did we find? What we found was, in fact, quite dramatically that the conditions in which people got this Otago exercise program combined with the interpersonal behavior change strategies, right? Those sort of more peer-based, group-based discussion strategies, they um, they we had much greater success. And so what are you seeing on this graph? Let me just sort of orient you. This is the sort of adjusted, this is increase in total activity that these people report from baseline, right? So baseline is all the way at the left, it's 0. The yellow dotted is the people who got the intrapersonal behavior change strategies. The bluer, darker dot are people who got the interpersonal strategies. And then the 3 time points are what are assessments that were taken objectively monitored with these Fitbits, either both 1 week, 6 months, and 12 months. And what you can see is quite clearly is that the interpersonal behavior change strategies really led to much, much more increase in engagement in physical activity, and really in a way we were really thrilled about. And that difference sustained itself for a year after the intervention, right? So these people stopped getting the intervention, but they sustained that level of activity 12 months out. Um, and so what can we conclude from this? I'll note a couple of things. First, this finding actually replicated a smaller scale study that the same group did a few years earlier. In fact, it was that initial study that enabled us to get the NIH funding to do this larger trial. And what can we conclude? I think we conclude that interpersonal behavior change strategies look like they might be an effective tool for motivating older adults to engage in physical activity. And these intrapersonal behavior change strategies do not seem to be effective, at least in a community of older adults, which is a little surprising because there are a lot of strategies in there that we sort of have a sense or know are things that people that can be in lots of other settings to be effective. What's also interesting here, and I'll just sort of note, like some glasses, I guess, are half full, is that while we've seen pretty consistent evidence that these interpersonal behavior change strategies seem to be more effective in this population to promote physical activity, we've really been unable to identify why, right? So that mechanism that I sort of was emphasizing at the beginning, sort of that's so critical, all the ones that we thought the interpersonal behavior change strategy might operate through, we just haven't seen evidence for that. And so that's a real struggle and a gap. And I can opine about that, but I know I want to save time for questions. So I want to turn to finally sort of just a couple of things that are in my mind as I think about where we are headed. And so I'm going to sort of just quickly talk about 3 things that I think are things that are a few key questions that my colleagues and I are really thinking quite a bit about. The first is this question about what actually about a construct should be modified, right? So I've been sort of telling you that these mechanisms are really important. I'm sure almost in the way I've talked about it, this is probably true, but almost always when we talk about mechanisms and change, we're almost always talking about level or value, right? Can we make people think more favorably? Can we increase or decrease the level of people's risk? And that often is something that we want to do. But there are times when, in fact, it isn't actually changing what people think, but really what we need to do is change the level of accessibility, or sort of think about it as how easily it comes to mind, right? In other words, the problem isn't that people don't have the wishes, the intentions, the sense of ability, whatever it might be that we think is a key driver of the behavior. It's just not salient, right? And so one of the things that some of my colleagues and I have been trying to work out is sort of the idea that there are different sets of strategies that we might want to turn to and be thoughtful. What do we really want to do here? Do we want to change how people are thinking, or do we just want to activate the thoughts and feelings that people have? And I think sorting that out and specifying when we want to change and when we just want to activate what people are already thinking is a key challenge for moving forward. A second one is something that is what I call sort of a behavior change strategy prescription, right? Or like, what is the right dose? for an intervention strategy. And in the behavior change literature, we not almost exclusively talk about sort of should we or should we not use an intervention strategy. And so, should we provide reminders or not provide reminders? Should we give people information about the consequences of engaging in the behavior or not give them that information? Little is known regarding, well, what's the right dose for an intervention strategy, right? So what's the right amount of information or the frequency with which we provide it or the duration in which we provide it? Are, in a sense, in the same way that we prescribe other kinds of medicine all the time, right? So how do we prescribe behavior change strategies? Are there strategies that we're currently using that are actually being underutilized, right? That if we use them actually more, if we increase their prescription, they would be shown to be more effective. And are those actually that are being overutilized, right? That they actually be more effective if we provided them less frequently or with less content or for less duration. I offer just a paper here just to point to it, which is not really an answer to any of these questions, but just, I think, a really nice example that led by some of my colleagues to sort of begin to even just think about that. And it takes the behavior change intervention that we used with the older adults in physical activity and just tries to even just try to describe what was the dose that we used in that, right? What was the duration, the amount of time we spent on different things? I think this is a really important point. And then last, I think the other thing, something that I really actually think is really quite important is that these mechanistic processes that we're interested in really actually are probably in many ways conditional. That is, that there are certain things that need to be in place. There are certain conditions that have to be in place in order for them to hold. And that there are things that need to be in place in order for certain mechanisms to actually have an effect on behavior, right? So for example, giving somebody a strong intention is not going to be that effective if they don't have access or the resources in which to act on that intention. Similarly, there are going to be things that are going to regulate the impact of an intervention on its ability to change a mechanism. And we just need to do a better job of sort of articulating what those are. I mean, in some sense, an example of where this did work was when we showed earlier that it was people who were struggling when they were quitting smoking. Those were the people who responded to a particular intervention. Okay. So, and I think that is a key question. So finally, efforts to develop effective and efficient strategies to promote sustained behavior change remains an ongoing challenge. As I often tell my graduate students, we're not about to put ourselves out of business. I think this mechanistic approach to behavior change is offering us a systematic way to advance the science and practice of health behavior change. And if you're interested in this, as this catches your attention, I've been talking primarily on a perspective that's grounded in the science of behavior change perspective, but I want to just highlight two others. The Health Behavior Change Project, led by Susan Mickey, actually in the UK, that I have some involved in, and then the Center for Advancement and Dissemination of Intervention Optimization that Linda Collins runs. This is actually at NYU. These are places, if you're interested in this topic, I think you'd find lots of interesting resources and ideas. So let me just say thank you and just note lots of collaborators. This thing doesn't happen without them. It doesn't happen without money. And I'm happy to take questions. So Amna, I see you. And so let me stop sharing, right?
Yes, thank you so much, Dr. Rothman, for that incredibly insightful and fascinating presentation. I mean, I really appreciated how you walked us through not just like the what of behavior change, but the how and why, and especially your emphasis on taking more of a mechanistic approach to understanding behavior, and also how you broke it down, the distinction between like what helps people initiate change versus like what actually helps them sustain it over time, and how those are driven by the different underlying targets. That was particularly helpful, and I also found it really valuable how you highlighted the specific targets like intention, self-efficacy, as well as goal setting for initiation when it comes to maintaining it. And so now we're gonna transition to the discussion portion of our conversation today. So please utilize the Q&A feature to submit any questions that you have. We've already received quite a number of excellent questions, and so we're gonna try to get through as many questions as we can in the time that we have remaining. Before we get started, y'all already know it's not a fireside chat discussion without getting our fire started. And today in Minnesota, it's a bit warmer, but we got to get it started to set the vibe. So submit your questions and So there's one question that has
Mhm,
been submitted.
mhm.
Dr. Rothman, tell us. So how can we support people who are not ready to or are motivated to change their behavior? What are your thoughts?
Well, it's a great question, and again, I think although I didn't really have a time to talk too much about this, right? So I think what the particular challenge there is may actually vary importantly by the behavioral domain we're talking about, but to sort of just try to think about that broadly, I think one of the things we really need to think carefully is is what is the basis for that state of mind, for lack of a better word, right? So is the lack of interest or readiness a function of is it because there are things that are sort of inhibiting that, right? There are barriers that need to be removed, right? It depends. It's sort of hard to do this concrete, but sense of sort of concerns that need to be allayed, perhaps, or is it because there isn't a sense of knowledge or awareness or ability, sort of sense of personal relevance? There are any number of different kinds of intervention strategies out there. I mean, the thing that sort of comes to mind that is often used in this space is a process that some people may be familiar with, sort of called motivational interviewing, which sort of helps people themselves sort of come to some self-understanding of sort of what this issue is and what it might mean for them as a way sort of coming to maybe discover a sense of interest. I have a former graduate student, Austin Baldwin, who now at Southern Methodist University has done a number of interventions where he uses what he calls a self-persuasion processes, which instead of giving people pamphlets or information or showing them a video, you actually have people write their arguments themselves, right? So they sort of the task is actually write out why there are benefits to being more physically active or eating a diet sort of richer in fruits and vegetables. And he's actually shown interesting that self process, right, is actually quite effective and effective more in a more broader way than you might imagine. And in a couple of instances, is actually was more effective than giving people sort of structured formed handouts.
So there's another question that was submitted. To what extent does mental health modulate the
Oh
effectiveness of
my gosh.
health behavior change techniques, especially in folks already diagnosed with cancer who are susceptible, goodness,
Yeah. Yeah.
to the psychopathology?
So again, just such a great question. And I'll almost use it first to shout out a colleague of mine, Marco Iser, who's so this is sort of peripheral, but I think relevant, who's in the Hubbard School of Journalism and Mass Communication. And Marco's expertise is more in health communication. So it's really more about those kinds of strategies. But his particular interest is understanding and developing communication strategies that are effective for individuals who are struggling with different forms of mental illness. And so I almost point to Marco just because that's his expertise, but I think it's a phenomenally good question, right? We need to be thinking carefully about. I might even sort of just say I don't have a concrete answer, but I would say that last sort of idea that I presented about the idea that the way these mechanistic processes are going to operate are going to vary depending on sort of some conditional factors, right? So we might expect that sort of strategies that we're using and this is, I think, what Marco is actually demonstrating in his work, strategies that we might normally use to maybe help people feel more engaged, more motivated, more sense of efficacy, might work differently depending on whether people are in different depending on sort of people's mental health, and so we would need to use maybe different strategies for those people to engage the same mechanism, or it could be that we have to engage different mechanisms for these different people. And so, I'm sorry I don't have answers, but I think I'll just hopefully you can get energized by the fact that I think these are just exactly the kind of questions you want to ask.
Yeah. And there are so many questions, really, really good ones. So keep them coming, folks. This one's a very relevant question.
Mhm.
Has there been any recent news or research related to the impact of GLP-1s on health behavior change?
Great question. And the answer is yes, right? So there's a lot of interest in this. The perhaps the unsatisfying part is I'm going to have to say, but I'm not the person to answer that. I'm not the person to answer that question. It's not an area that I work in very frequently at this point. And so but it really isn't, it's a really, I mean, it's sort of, as I think about it, I think it's a really interesting question, right? Sort of um, you know, how do we think those kinds of behavior change strategies operate, right? So like do they not require certain, you know what I mean? Sort of might they not require sort of some of the cognitive and affective changes that might necessarily be necessary to support more active behavioral changes, like, changing your diet and your physical activity? And if that's the case, I guess this is all speculation. So please, caveats everywhere, right? But it could well be that if it doesn't, right, then things like those kinds of medications, they work as long as you take them. But the second you stop taking them, not only do you no longer, I guess, get the pharmacological effects, but you also don't necessarily have the mindset that would necessarily help you maintain a pattern of behavior that would be beneficial. It's sort of what in social psychology sometimes we talk about compliance versus conversion, right? So that you've engaged in a pattern of behavior that's compliance, but you haven't changed your thoughts and feelings underneath that. So that once the conditions for compliance go away, you change your behavior back. As opposed to conversion, which is the idea that you've changed your behavior and you've changed sort of the underlying thoughts and feelings so that when the sort of requirements or the edicts are removed, you will sustain that pattern of behavior. So, but boy, that's speculation. So.
Fascinating. I'm excited to see the research that will emerge. So, what specific factors are responsible for failures in health behavior change, and what practical techniques are useful in eliminating those?
Whew. Um, Well, I do. I'll offer maybe a couple of observations. One that I actually was thinking quite a bit actually as I was talking, and it's an interesting topic that has emerged in this area, which is almost all of the examples that I've given you, and almost all the things that typically my colleagues and I work on are what are thought of as individual level behavior change, right? So it takes sometimes a phrase. I don't know if this is anything familiar, but it's sort of an I-frame perspective, right? Sort of the idea is we have to change what the individual thinks or feels or is, sort of able of doing. And there are people who sort of say that perspective needs to be robustly accompanied by what is characterized as a system level or an S-frame approach, right? And so, um, and and I think that's and I think success in this area really ultimately needs to be is based on sort of a combination of these approaches. But I think not always, but many of the things that make behavior change so challenging are in fact the broader social structural situations that we find ourselves in, right? And so, things like um, what opportunities and availability do we have to be engaging in physical activity? Sort of, so what is the state of the green space and the public space that's available to us? Do I have access to gyms and facilities? What is the state of, what's the availability of food, and what kinds of foods are available and affordable to me, right? So structural factors, are often quite pernicious and often are not necessarily, are often the challenges that people have to navigate, right? And so even when they're trying their best. The other thing buried in this, and you will see this in a lot of programs, is just the critical importance of sort of learning from challenges, right? So in other words, getting insight from, things that you did that were sort of less beneficial, and understanding that those are the things that might be key barriers for you, key things that trip you up.
Mhm. And there is kind of a little bit related question, and this will be the last question, but it's a really good one that I want to ask you. So,
Okay.
how does stress, trauma, adverse childhood experiences
Oh,
shape
great.
a person's ability to make and sustain health behavior change?
Well, I think it's
It's a big one,
these
but
are
I
all right. That's a big one. These are all just critical drivers, right? And we need to really think. I think what I would say on this is we really need to think systematically about um, how the strategy. I'm sort of going to back up to the same question that was asked earlier when we were talking a little bit about sort of how do you navigate behavior change in the context of somebody had asked it and framed it more in terms of, sort of mental health challenges. I think the things we need to sort of think carefully about is we might have a I'm sorry but we have a mechanistic process that we're interested in. And the question I think we want to ask is for people with different types of backgrounds, such as, the ones that were just pointed to in this question, um, are the things that we need to target, with the targets we need to engage to help motivate their behavior, are they the same or are they distinct? Like, is there a different set of mechanisms that we have to engage with, right? So it might be that in some domains, there's a slightly distinct set of mechanisms we have to target in order to help them engage in the behavior, and or are all the mechanisms that we're trying to change the same, but we got to use slightly different strategies, right? So in other words, right, so that in a sense, this often comes up. We want to help people feel confident in their ability, but perhaps the strategies we use to help them navigate that, help them accrue that sense of confidence or self-efficacy might be different depending on people's life experiences and background. And we've got to figure that out. I mean, one of the things that my colleague Pascal Sheard and I have been arguing is that currently even interventions that we know are effective, that the evidence base is pretty good, underneath that effectiveness is an enormous amount of heterogeneity, right? Do you know what I mean? It works on average, but doesn't work for everyone. And one of the things we need to understand is what can we learn about that heterogeneity? I don't know enough to say that sort of for, the instances that were asked in this question are all necessarily the drivers of that heterogeneity, but they could well be. In that case, we need to understand sort of what do we need to do better and differently for people with slightly different life experiences and backgrounds. So that's an insufficient answer to a really important question, but it gets us started.
Yes, and I think we're gonna have to wrap it up now. But before you leave us, would love to ask you one final question. If there's one key takeaway that you hope our audience leaves with when it comes to understanding or supporting behavior change to promote health, what would that be?
I'll offer two. One is that behavior change is and the strategies we use to that, so we need to think about them in the same way we think about other kinds of treatments, right? So in other words, one of the things I often say to my graduate students is, like, in the same way that we think about certain medications, right? You take penicillin for an infection. You don't take penicillin when you have a headache, right? There's a specificity there. And I think we have to think about that in the same way with these behavior change techniques. If we want to help people change, that there are certain techniques that are going to be effective for certain behaviors, certain classes of people, certain contexts. And we need to develop the evidence base to support that. But if we can develop that evidence base, we really should be in a great position to help people successfully make the changes that they'd like to make, and hopefully then also be able to sustain those changes. So I know we're over, so I'll leave it. I'll leave it at
Yes,
that.
what a great way for us to wrap the conversation up. Thank you so much, Dr. Rothman, for sharing your expertise and for helping us better understand the science behind what drives behavior change. Before we officially close, I just have very quick things I would like to make note of. So we would greatly appreciate if you could take the time to complete a very brief survey. It will auto-populate as soon as you exit out of the Zoom webinar, and it will also be included in the follow-up email that will be sent out tomorrow. Your feedback truly helps us continue to improve the series and to bring you timely and relevant topics. And as a small token of appreciation for completing the survey, you will get the opportunity to enter into a drawing for a prize pack. And the drawing link is available after you submit the survey. So don't close out of the survey after you complete it. And the prize pack is filled with goodies from the Masonic Cancer Center. So you don't want to miss that link. We also hope that you join us for our next Fireside Chat on May 21st, same time, same place. It will be Bladder Cancer Awareness Month. And so we're going to be joined by a urologist and a bladder cancer survivor for a conversation that brings both the clinical and lived experience. So the link to register will be included in the follow-up email in tomorrow's email. And then also we would like you to stay connected with the Masonic Cancer Center. So be sure to follow us on all of our social media platforms. You can also subscribe to our monthly Community Matters newsletter to learn about all of the upcoming events and resources from the Office of Community Outreach and Engagement. The link to subscribe will also be included in the email that will go out tomorrow, in addition to Dr. Rothman's presentation. So thank you everyone for spending your afternoon with us, for spending a little bit over the hour. We appreciate your time and engagement, and we hope to see you in May. Take care, everyone.
Bye.
Bye bye.